Welcome back guys. Now in this video, let's discuss about those anemias which are going to cause intravascular hemolysis. Already we have discussed about the extravascular hemolytic anemias. Now in this video, let's discuss about intravascular hemolytic anemias, which means the RBCs are getting destroyed within the blood vessels. Okay. Now let me tell you one thing. See, here there is predominantly intravascular hemolysis, which doesn't mean that there won't be any extravascular hemolysis. Yes, of course, there will be extravascular hemolysis also, but mainly it is intravascular hemolysis, and the same is true with the extravascular hemolysis also. Okay, extravascular hemolytic anemias. Mainly there extravascular hemolysis is happening, but there also intravascular hemolysis can occur. Okay, so having said that, now let's begin with the first type of intravascular hemolytic anemia. The first type is paroxysmal nocturnal hemolytic anemia. Okay, paroxysmal nocturnal hemolytic anemia. Okay, simply PNH. Okay, PNH, paroxysmal nocturnal hemoglobin. See what exactly is happening in this condition, paroxysmal nocturnal hemoglobinuria. See, paroxysmal, what exactly it mean by paroxysmal? Sometimes, paroxysms, sometimes. Nocturnal, during night, there is hemolysis that is happening. Okay, paroxysmal nocturnal hemoglobinuria, and hemoglobinuria is going to be there. So hemolysis is happening during the night, and that's what is causing the anemia. Okay, that's what is causing the anemia. Now, why in paroxysms, why during night time there is this hemolysis happening? We have to discuss about that right now. Look guys, this paroxysmal nocturnal hemoglobinuria, it's acquired. It's an acquired defect. See, it's not inherited, it's acquired. Okay, so acquired defect in myeloid stem cells. Okay, at the level of stem cells, there is this acquired defect. Now, what is this defect, sir? Okay, so due to this defect, what exactly happens is, let me tell you, this is something normal. See, this is the RBC. Now, on the surface of RBC, there is a protein present. Okay, there is a lipid-anchored protein that is present on the RBC. See, this protein which I am showing here in pink color, okay, this is the lipid-anchored protein which is called as GPI, glycosylphosphatidylinositol, okay, triphosphate, GPI, glycosylphosphatidylinositol. So, GPI. See, this protein, it is there throughout the surface of the RBC like this. Now, what is the importance of this protein? Is, say, this protein is hanging on to two more structures, two more proteins, which are called as, see, it's having two hands. With the help of this GPI on the surface of RBC, there is something called as DAF. What is DAF? Decay accelerating factor. Okay, decay accelerating factor. And with the other hand, there is something called as MIRL. Okay, so membrane inhibitor of reactive lysis. Okay, membrane inhibitor of reactive lysis. So this DAF, it is designated as CD55, and this MIRL, it is designated as CD59. Okay, DAF and MIRL. See, this DAF and MIRL, what they are doing, what is the function? See, they are going to inhibit, they will inhibit what? They will inhibit activated complements. Okay, they will inhibit the activated complements. For example, if any activated complement is coming towards the RBC or WBC or platelets, see, this GPI is going to be present on all the blood cells, not only RBC, that is also present on WBC as well as the platelets. Now, if by chance, if any activated complement is coming near to the RBC, WBC or platelets, this DAF and MIRL are going to inhibit the activated components. See, let me tell you what exactly is the story. See, now imagine this is your blood vessel, sir. Okay. See, in the blood vessel, blood is there, plasma is there, cells are there. Now, for example, say this is your RBC. This is your RBC. But in your blood, there are also other proteins which are called as complement proteins. See, these are the complement proteins. See, these complement proteins, once they are activated, okay, once the complement proteins, let me write here, these are the complements. See, these complement proteins, they are inactive. Okay, they are inactive. Because of some reason, if they are getting activated, okay, because of some reason they are getting activated, sir, because of some bacteria, you know, in inflammation topic we have discussed, there is something called as a general classical pathway, alternate pathway, okay. There are different pathways of the complement activation. Yes, complement is activated, maybe because of bacteria. So, once the complement is activated, the activated complements, they will produce something called as membrane attack complex. The membrane attack complex, the activated complements are going to produce the membrane attack complex. See, this membrane attack complex, it will kills bacteria. Okay, it will kill the bacteria or the fungus. But the problem is, this membrane attack complex doesn't know whether it's bacteria or it is our own cell. Once the complement is activated, yes, there is membrane attack complex. Once the membrane attack complex is there, it's going to put the it's going to act like a drill, sir. It's going to act like a drilling machine. It's going to put holes into the cell membrane and cause the death of the cells. It doesn't know what is our cell or the bacteria. So this membrane attack complex will also trying to come to the RBCs, WBCs and platelets, and this membrane attack complex is trying to attack our own cells also. So our own cells should have its own protection. Our own cells should have its own protection. So what is our own protection? DAF and MIRL. So DAF and MIRL, which are present on the surface of our blood cells with the help of the GPI molecule, what it is doing? It is inhibiting, okay, it is inhibiting the activated complements. Any activated complement or the membrane attack complex, if it is coming near to the blood cells, the complements are going to be inactivated. Okay, the complements will be totally inactivated. Okay, so this is the function. Now, what happens if there is inherited defect? Sir, what is the inherited defect? Now, inherited defect is this GPI is not available. Okay, this GPI, it is not there. When GPI is not there, okay, see, look, this GPI is not there, sir. If GPI is not there, do you think DAF and MIRL will be there? No, there is no DAF and MIRL. If there is no DAF and MIRL, what happens? Sir, there is no inactivation of the components. Let me write here. In this paroxysmal nocturnal hemoglobinuria, there is absence GPI. That leads to absence of DAF and MIRL. Okay, DAF and MIRL are also not there. Decay accelerating factor and membrane inhibitor of eculizumab, they are not there. Whenever they are not there, once the complements are activated complements, will attack blood cells. Attack blood cells. Okay, not only RBC but also WBC and platelets. The activated components, that's the membrane attack complex, okay, will attack the blood cells. So RBCs are getting destroyed within the blood vessel system. The membrane attack complex is going to cause the lysis of the RBC within the blood vessel itself. So that's why intravascular hemolysis. Okay, so the patient is going to have the intravascular hemolysis. Now the question is, why this condition is called as paroxysmal nocturnal hemoglobinuria? Okay, why the name nocturnal? It is because, see, during night, okay, during night, what kind of breathing we are going to have? We are going to have the shallow breathing. Now, shallow breathing is going to cause carbon dioxide retention. Okay, when you are doing the shallow breathing, the carbon dioxide washout is not properly happening. So that will cause increased amount of carbon dioxide. So the carbon dioxide will react with the water and forms H2CO3. So now the patient is having carbonic acid. So that causes acidosis. Okay, the patient is going to have acidosis, sir. Okay, so now this acidosis, okay, now this acidosis is the one which activates the complements. Yes, acidosis is thought to activate the complements. So during night, Okay, some nights the complements are activated. The acidosis is activating the complements. Now the activated complements are going to cause hemolysis. Okay, is going to cause the hemolysis, and the hemolysis is going to cause the hemoglobinemia. So because of this hemolysis, what happens? What do you think? RBCs are getting destroyed within the blood vessel. So when the RBCs are getting destroyed, hemoglobin is going to leak into the blood. So hemoglobinemia. Hemoglobinemia is there. Okay, hemoglobin is going to leak into the blood. Hemoglobinemia. This hemoglobinemia, whenever this hemoglobin is there, the hemoglobin will also come into the kidneys, and there is going to be leaked into the urine. So hemoglobinuria. Okay, hemoglobinuria. Of course, this hemoglobin, whatever is there in the blood, that hemoglobin will be binding with haptoglobin levels. Okay, will be binding with the haptoglobin. So what happened to the haptoglobin levels? The haptoglobin is getting now binding with the hemoglobin. Okay, we are not supposed to simply leave the hemoglobin just like that. So hemoglobin, it's a protein. It's going to be bound with the other plasma protein, which is called as a haptoglobin. So haptoglobin levels decreases. Okay, haptoglobin levels decreases because now there is no free haptoglobin. Haptoglobin is going to bind with the hemoglobin. So hemoglobinemia is there, hemoglobinuria is there. Now the hemoglobin is going to be reabsorbed in the PCT cells. Okay, reabsorbed in PCT cells. Now after some days, the hemoglobin is getting actively reabsorbed in the PCT cells. In the PCT cells, the hemoglobin is going to be break down. The iron is going to be break down into hemosiderin. Okay, that hemosiderin is accumulated in those cells, and these cells will sort off and they will come out in the urine after some days. After the days after hemolysis, these let me put it this way. Sir, here imagine this is the nephron, and what is this? See, this is the proximal convoluted tubule. So these are the epithelial cells lining the proximal convoluted tubule. The hemoglobin is going into the cells. The hemoglobin is being reabsorbed into the cells. Now, after reabsorbing into the cells are going to break down this hemoglobin into hemosiderin. Hemosiderin is nothing but the iron pigment. So after some days, because of the turnover, these cells will slough off. So days after hemolysis, you can even see hemosideриnuria. Okay, hemosideриnuria is going to be seen. So that's why the name paroxysmal, sometimes nocturnal, during night there is hemolysis occurring. So when the patient goes to the urine, so it's going to be red color urine. Paroxysmal nocturnal hemoglobinuria. Okay, the exact name is paroxysmal nocturnal hemoglobinuria. Okay, so this is the point which I want you to know. So now what is the screening test? Screening test for this patients. Screening test. So screening test is sucrose test. Sucrose test. See, what is the sucrose test? See, sucrose is going to cause the acidification. Okay, sucrose test, okay, is going to cause acidification of the plasma. Acidification of serum. So when you do the acidification of the serum, okay, tell me what happens. Hemolysis is going to happen because acidification is going to activate the complements. Once the complements are activated, RBCs are going to getting lysed. So this you can do. So sucrose test. See, the confirmatory test. Confirmatory test is flow cytometry. Okay, flow cytometry. In flow cytometry, we are going to see each and every individual protein, whether everything is there or not. Okay, now you are going to take the RBC and like you are going to send it through the flow cytometry. Now you will see whether all the components are there or not. Now if you do the flow cytometry, what you will see, there is absence. The test will come. There is absence of GPI on the RBCs is absent. Not only on the RBCs, WBCs, platelets also. Now what is the most common cause of death? The most common cause of death in these patients is, see, if RBCs are getting broken down, oh, that's okay, that's going to be hemolysis. But in this patient, not only RBCs but platelets are also getting broken down. So the breakdown of the platelets, activated complements are also causing the breakdown of the platelets. So that thrombolysis, or I should say the platelet breakdown, okay, not the thrombolysis, the platelet breakdown is going to form the thrombus. Okay, it's going to cause the thrombosis. So, the thrombosis, intravascular thrombi, the thrombosis is the one which actually kills the patient. Okay. Next, apart from this, so these patients are at a risk of developing, there is a risk of developing acute myelogenous leukemia. These patients in the future they can develop acute myelogenous leukemia. Okay. So, this is the complication which I want you to know. So, with this paroxysmal nocturnal hemoglobinuria, the first type of intravascular hemolytic anemia, that is completed. In the next video, we will be discussing about other intravascular hemolytic anemias. Hope the video is helpful. Thank you.